The way we calculate our bad debt, that's not accounts that have been written off. That is a reserve or an allowance based on what our balances are in our accounts receivable. So if we have self-pay revenue that's aging out there, you know, when it gets over 180 days old, we start allowing for that, or reserving for that at 100% of it. So that's kind of a concern for us. A number that we'll want to watch, and we'll look at a comparison a little bit. We're about 5.6% of gross charges, and last year we were maybe 5.2. So it's trending up a little bit, and we've talked with the finance committee about how to manage that. You know, certainly one of the things that we talked about a little bit is do we want to triage our patients differently in the emergency room. Right now, you know, anyone that presents, any patient that presents in the emergency room, they have to have an initial medical screen to determine, you know, their level of care that they need. You know, it's certainly an option that we'll be talking about a little bit, is we can triage them differently. Those that come in with a with a minor illness that doesn't require you know, emergency treatment, you know, we can triage those to a different setting. You know, we have either a physician or a nurse practitioner that could treat those. Right now, all of them are, yeah, Ernie?
I want to address this bad debt and some charity care. You know, we're a community hospital, and we get the complaints about our billing. He talked about self-pay, and I hope in a minute he'll go through and explain the mechanics of a person coming in with insurance and being treated, and then after the insurance makes their payment to us, then the balance goes to self-pay. And dealing with insurance companies, sometimes it's a long time. And so that's where we get some of our complaints. But on bad debts, and he's talking about emergency room situations, I think that we as a board, and today's not the day to even decide this, but we all need to be thinking of what's our mission in our community. When are we going to tell a person that walks into that emergency room, or a person needing our services in our hospital, that we're not going to do it? So, I mean, that's going to be our option. You know, if a person comes in the emergency room, they really don't have the ability to pay, are we going to tell them they got to go someplace else? Or if somebody comes in the hospital, are we going to tell them that they don't have the ability to pay, or that they need to go someplace else? So we're going to have to decide where our place in our community is with this, in my opinion.
Yeah, and I think that's the challenge for us in terms of managing our bad debt. Is you can manage it more aggressively than what we're doing right now. But that's
and it affects our cash position seriously. And you know, we're struggling a little bit with the money right now, but it's something we've got to deal with.
Are you allowed to evaluate people coming into the emergency room and determine whether they're really emergencies, or whether they know they can't go to the doctor because they don't have the money and they just come around there?
They're required, we are by law, by federal law, required to medically screen them, which in our case, and you can make some very distinct exceptions through some hoop jumping, but basically the doctor has to see them. So, and the doctor in the emergency room would then have to make the decision as to whether or not that patient has an emergency medical condition or not. If they do not have an emergency medical condition as determined by the physician, then you can say to that patient, I need you to pay, or we cannot complete your treatment.
But at that time,
that's not our practice.
But at that time, if they already technically spent the $700 for the emergency room and the $175 for the doctor, I mean, at that point, that's already been obligated.
To some degree,
there is
yes.
There is no lesser amount.
That's right. Another thing, doctor may, in order to determine emergency or not emergency, may decide before I can make that decision, I may need to do an X-ray or maybe.
And I understand that, but there is no gate there that you can say, that to get the desk, there's a
No.
exam or anything.
No.
A lot of people think we do triage, a nurse does a triage when the patient comes to the ER. A lot of people think that once that triage is done, that's medical screening.
And that's not.
And that's not the case. The medical screening has to be a screening decision by a physician. So they've already gone through a significant part of the ER process by the time we can make.
So there's really no reason to not treat them at that point.
That's right, because they've incurred some
You've already
expenses.
done it.
Yeah, the difference is at that point, you can require payment, for instance, before you give them a prescription.
Okay.
Or, you know, so you can handle it, and then you just balance the public relations.
You can say,
issues.
I know what's wrong with you, I know what's wrong with you, but I'm not gonna tell you anything.
Walter, you looking for
Exactly.
a part-time job, we'll put you down there to let you tell them that.
And we opted as a community facility
while I'm
over
thinking,
time not
Ray,
to do that.
You need to keep me abreast. We are switching agency health coordinators. So
Oh, okay.
I don't anticipate any change, but if you have any problem, let me know. I think she's gonna be great. I mean, Linda's done such a good job the
Yeah.
last few years. It's
That's a
just,
great job.
we've been spoiled. It's just,
Who's going to be doing it, John?
Dana used to work for Milton, I forget.
Okay.
Larry Sifford's daughter. You
Okay.
and I
Yeah,
understand. You and I understand that.
Is our protocol any different?
Yes.
Yes.
All right, you're talking the difference between CHS and CHC.
Well, yeah. It's a philosophical decision.
You know, these people that come in that can't pay, doesn't get up on the statement, and we don't ever get applied discounts and allowances for that $700 emergency room. It just goes to bad debts.
That's right there.
Sounds like that's a topic for a future meeting.
Yeah.
And I will tell you, the finance committee is addressing that. One other comment on that, which Ernie alluded to a little bit, is on this, is the other issue that we face on bad debt has to do really with the change in insurance coverage. As premiums go up, you know, more and more people are switching to a higher deductible plan, and with these higher deductible plans, you know, particularly during this first quarter, the first part of the year, and all, people got got to meet their deductibles first. I mean, it's just more and more difficult to collect that. And you see that more on the 501A side with the physician side, where you even have a Medicare outpatient deductible there.